The one thing I learned was that there is some overlap between Unni and my talk. So what I will do is I will make sure that I pause appropriately and let him take over this thing. I have no conflicts of interest. Let's start with the patient because this helps us understand this much better. Here's a 64-year-old man who presents with fatigue, weakness, and loss of libido. He has type 2 diabetes for 18 years. 5 years prior, he had undergone CABG. He lives with his wife. His only daughter is undergoing a divorce. Until very recently, he has had intercourse 3 to 4 times a month. Of late, he says the desire is not there. There's no weight loss, loss of muscle mass, gynecomastia, or secondary sexual characteristics. Testis using a orchidometer is about 18 cc. Blood pressure is fine. BMI is around 24. A1C is good. EGFR is 84. TSH is 1.1. The rest of the exam is normal. The patient is on DPP-4 inhibitors, metformin, and ARB, and a statin. So let's see which one of the following is the most appropriate. A trial of antidepressants. B, reassure that this is normal for his age. C, trial of tadalafil citrate. D, measure total testosterone, or E, measure free testosterone. How many people think A is the right answer? Give him antidepressants. His daughter is going through a divorce. Nobody wants to do that. Coffee for anyone? B, how many think this is normal for his age? No one? How many think a trial of tadalafil is a good idea? A few, okay. How many think you should measure a total testosterone? How many think you should measure a free testosterone? Everyone wants to measure a free testosterone. Okay, so then this talk is worth it. So remember that male hypogonadism can occur at any time. And there are some simple ways to look at how it occurs. If the onset is before birth, especially before the 3rd trimester, the patient is usually born with an ambiguous genitalia, right? If the onset is in the 3rd trimester, then the genitalia are fully formed, but you have a micropenis. This is a simple way to think about it. I'm not going to do an endocrine talk. This will be a very uncomplicated talk for all of us, remember. Anytime patients can have cryptorchidism, and this can cause hypogonadism. The second time it can happen is after birth, and then the onset can be at or before puberty. There you can have a failure to undergo puberty completely, or you can have failure to complete puberty, which means the secondary sexual characteristics are not there, a small built person, not having muscular strength, right? The ones we call puny, all of these are there. And then of course, it can occur as an adult, where the predominant symptom will be a decrease in libido and energy. There could be infertility, and of course others such as osteoporosis. Dr. Bansali has given a huge talk on this. I'm not going to go into it. Now the simple way to look at it, that usually the one thing I want to remember is when I was an endocrine fellow, one of the things that you carried in your pocket was a birchwood orchidometer, right? And now I realize that it's not necessary. You should get an ultrasound probe. But at the lowest and the highest, the orchidometer underestimates the testicular size. But for most of the others in the middle, it's fine. But if the testis size is less than 20 cc, or the phallus size is around 8 centimeters, look for unicoidal proportions. This is very easily recognizable. You could see the upper limb, lower limb proportions. Look for underdeveloped secondary sexual characteristics. Each of this tells you that this has occurred before puberty. Correct? The one thing that is a very, very good clue is the presence of gynecomastia. If gynecomastia is present, then this is primary. A lot of us think that, if somebody has hypogonadism, then they should lose their facial hair or the body hair or this thing. This doesn't happen. It takes many, many, many years. Therefore, it's very difficult to clinically recognize hypogonadism that has occurred later in life. But over a period of time, 5 years, 10 years, people may lose muscle mass. They may become more obese. Their waist-hip ratio may increase. They will have decreased exercise tolerance. These are the things to look for. Now, should you screen for hypogonadism? A lot of people have talked about screening in various circumstances. I think there is no data to support a population-based screening for hypogonadism. However, there is a role for case finding. Who should you look for? Anyone who's had pituitary disease, correct? People who've been given drugs such as glucocorticoids, opioids, patients who have abused substances for a long period of time, right? Then HIV, any patient with HIV associated weight loss, ESRD, long-standing lung disease, infertility of course, and in men especially osteoporosis or low trauma fracture. And in type 2 diabetes, you must have a low threshold for diagnosing hypogonadism. What are the features? Generally lethargy in adults. All the features of hypogonadism are the features of life. Lethargy, fatigue, coming home to the same partner, right? But low mood, irritability, headaches, sometimes hot flashes, very rare. Incidentally detected osteopenia, loss of muscle, increased fat mass. Again, remember gynecomastia indicates primary. Decreased libido. Erectile dysfunction as a feature of hypogonadism is fairly uncommon. It's a very late feature. In the olden days, we used to say if there is no loss of libido, don't test for testosterone. That's not true anymore. If anyone presents with ED, at this point of time, most people recommend measurement of testosterone. So, when you have a clinical suspicion, a good point is to think about, normally in endocrinology, we do hormones in pairs, testosterone with LH and FSH is what you want to do. Let me start with testosterone because we need to understand testosterone well. Why do we need to understand testosterone? Is because it is one of the most difficult hormones to measure, especially the free thing. It circulates in the blood as free plus protein bound, right? It's bound to albumin and it's also bound to sex hormone binding globulin. It is also bound to a third protein that is fairly insignificant. But the free hormone is active. So normally, if you want to look at most labs, for example, the Endocrine Society's new data, they talk about between 241 and 792. In your mind, think about 300 to 800. If it is less than 300, it's significant. And that's the way to look at it. Now, how do you measure testosterone? Measure it in the morning, an 8 to 10 a.m. sample. If it is the lower limit of normal, let us say you find 250 or 300 or 270 or 240, repeat it because this is very, very prone to errors. Then there are conditions where you need to think about whether the testosterone is actually affected by the proteins that bind to it. One is albumin. It really does not affect it so much. The most important is a hormone called sex hormone binding globulin. Sex hormone binding globulin is an important hormone for all of us to remember. It's decreased in many conditions that we treat. The most important one is obesity, right? It's also reduced in insulin resistance. It's reduced in hypothyroidism. It is reduced when other drugs are given. It is reduced in nephrotic syndrome, a whole bunch of conditions. This sort of tells you the difference. This is serum testosterone. This is in an obese individual where it is low. On the other hand, if you do a free testosterone by equilibrium dialysis, you see that it is redistributed. Previously, people used to think that in patients with obesity, that the testosterone is low only because of SHBG. Now we know that is not the case. That in a significant proportion of patients who have very high BMIs, let's say 38 or 40, that there is a component of hypogonadotropic hypogonadism that is reversed by reducing the weight. So in someone with extreme obesity, do not be in a hurry to treat the hypogonadism. Treat the weight first and then the hypogonadism may actually recover. So this is something you want to remember. So SHBG increases with age, with hyperthyroidism and other conditions. This is, for example, and again, when Unni talks about, he will talk about aging, and I will also touch on it before I close. Remember that as we get older, our testosterone seems to be coming down, but there is not such a marked decrease in free testosterone. This is simply because of the presence of SHBG. This is the EMAS study that looked at testosterone over 4 decades. You will notice that the total testosterone is sort of, this is the curve, and at the extremes you will find that the testosterone actually lowers. And the fact that the LH is increasing here shows that there is actually a true hypogonadism that is occurring in some of these patients. Should we treat or not treat, we'll talk about in a moment. So this is again a combination of 4 big studies. For those of you who are interested in the references, please note that the references are all there in the bottom half. So this is looking at, again, what happens in 4 decades over people. Remember that there is a total decrease of the testosterone by about 8.6% in 4 decades, which means 0.4% per annum. But at the end, you will find that between somebody who's in their 40s to somebody in their 75s or 80s, there's a 33% reduction in the free testosterone. And here all the free testosterone were done by equilibrium dialysis. So there is actual loss of testicular function as we get older. Is there an andropause? We can debate till the cows come home, but clearly there is a gradual decline. While in women the stroke is sudden, in men the poison is slow and steady. So, should we do free testosterone? The answer is absolutely not. Why? Because none of us, many of us, maybe Dr. Bansali has access to equilibrium dialysis, I don't. We use radioimmunoassay, and this is a horrible assay. Please do not ask for free testosterone. There was a time when we used to think that in women it sort of reflects total testosterone. Well, it doesn't. So neither men, women or children do not measure free testosterone. Measure total testosterone. If it is in the lower end, ask for an SHBG, right? And then use an online calculator like this to measure the free testosterone. These correlate very, very well with equilibrium dialysis, but do not measure radioimmunoassay free testosterone. Horrible test, right? So what do you do when you do that? Once you get the total testosterone, if it is low, then get an LH and FSH, because you want to find out whether it's pituitary or whether it is occurring from the testis. Most people will usually also get a semen analysis, and many times a patient having a low semen analysis, and generally when a low semen analysis is less than 5 million, the current recommendation is to measure testosterone, because it can be part of the syndrome. Remember that in primary testicular failure, the spermatogenesis is more impaired than the Leydig cell function. Both are equally impaired in secondary. So to go back to this patient, although the divorce could have affected their sexual life, this patient has symptoms, and he specifically talks about libido. Otherwise, he would have dismissed it himself. So trial of antidepressants is not the right answer. Certainly, you don't talk to women about age, you don't talk about sexual function as normal for the age. The general way to look at it is that people can have healthy sexual lives as long as they want it. So do not reassure that this is normal for age. A trial of tadalafil citrate is good in most patients, but I think this patient warrants workup. Do not measure free testosterone. Remember, in the board exams, E is always a wrong answer. So the correct answer in this particular patient is measure total testosterone, right? So here's a 64-year-old man. He presents with fatigue, weakness, loss of libido, and the total testosterone is 100 nanograms per deciliter. Let's look at 300 as somewhere we are close. So what should you do? 1, start testosterone enanthate. B, reassure that this is normal for age. C, measure LH and FSH. D, measure SHBG. E, start transdermal testosterone. How many people would start testosterone? A, no. B, we said we won't reassure. C, yes. Some people who are awake. D, E, okay. So in someone who's got clear-cut low testosterone, like this person, it's not like 250 or 240. You really don't want to measure an SHBG. This is really low. So you could use the testosterone value. What you do want to find out is whether this is primary or secondary. So remember that if the LH and the FSH, the upper value is more than 8 with a low testosterone, then this is primary hypogonadism. That is, the problem is in the testis. If the LH and FSH is high, look for a low sperm count. Sometimes you can have a normal testosterone, normal LH, and an increased FSH. This is usually seen in seminiferous tubule damage, right? This is primary, occurring in the testis. A whole bunch of conditions are there. It can occur from childhood. The most important one, of course, being Klinefelter syndrome. Klinefelter syndrome is someone who's got an extra X chromosome. One second. X chromosome will have gynecomastia, the picture is not there. Unicoidal habitus. They can have kleptomania. They can have social constructs, an increase in incidence of type 1 diabetes. In fact, there is one study that has looked at when you diagnose Klinefelter syndrome in infancy, giving them testosterone during infancy, actually improving some of the outcomes. This has not been seen everywhere else, but this is one of those. The other could be a mutation in the LH and FSH receptor genes. In patients with cryptorchidism, this is very common. Varicocele is not a very common cause of testosterone deficiency. And of course, you must think of antigen synthesis where a karyotype might even show that the patient has a different karyotype, right? So one of the things you want to consider is if there is a specific thing that looks like primary, like Klinefelter syndrome, get a karyotype on these people. Then there are other causes, infection, radiation, chemotherapy. Ketoconazole is a drug that interferes with steroid synthesis and should always be considered. Glucocorticoids, and this day and age, environmental toxins can do it, testicular torsion can do it, and systemic conditions can do it. So look this up, and then we go from there. Now, on the other hand, if the LH and FSH are not elevated, which means they are inappropriately low, then this is a problem in the pituitary gland. This is called secondary hypogonadism or hypogonadotropic hypogonadism. Again, this can be congenital. The one that most of us know about is a condition called Kallmann syndrome, where people have dysosmia, they may have nystagmus, they have central abnormalities, cerebellar ataxia, they could have a cryptorchidism, microphallus, indicating that the genital defect is in childhood. They can have midline abnormalities. So this is one thing. And if you see any of these, then it should prompt you to get an MRI of the sella, right? Also, it can be due to one of the most common conditions, especially that is overlooked, is a prolactin producing tumor. It could be also gonadal steroids. Always think about, especially somebody who is muscular, who think about androgen abuse, right? Then, of course, a whole bunch of pituitary diseases. So in patients who have LH and FSH that is not always elevated, think of a secondary cause of hypogonadotropic hypogonadism. If the testosterone is not modestly decreased, if it is like this patient is 100 or 80 or 150, I would get an MRI of the pituitary, measure a prolactin, get a free T4. Remember, a TSH can be falsely normal in someone with hypopituitarism. So when you measure a free T4, it will actually be low. So in this patient, the correct answer is not to give testosterone, not to start transdermal testosterone, not to measure SHBG, never reassure, measure an LH and FSH. So let's go back to this patient, 64-year-old, fatigue and weight loss, he had a total testosterone of 100, LH and FSH were not elevated, free T4 was 0.8, prolactin was 52, cortisol was 2.5, so there was multiple pituitary hormone deficiency. So what did we do? We got an MRI. This is a representative MRI. It showed a pituitary adenoma. The patient underwent transsphenoidal surgery. 1 month post-op, the testosterone was 89. The symptoms of fatigue and decreased libido remain. What should you do now? What is the correct answer to this patient? 1. Do the risks of testosterone outweigh the benefit? 1. 2. Testosterone is indicated. C. He's just had surgery, let's wait. 4. Right? On the other hand, walking ability mildly improves, vitality is not so much, and there's at the end of 1 year, in somebody who's symptomatic and hypogonadal, there actually seems to be benefit. So clearly in this patient who has symptoms and who has a low testosterone, the risks of testosterone therapy do not outweigh the benefits. Therapy is probably indicated in this patient. So this is where I'm going to hand over to Uni. So here's a 64-year-old man. He presents with fatigue, weakness, and loss of libido. Total testosterone is low. LH and FSH not elevated. He had an MRI of the pituitary. It showed a macroadenoma. He had post-op. He had a testosterone of 89. He was started by his doctor on testosterone gel. 3 months later, his wife reports with features of hirsutism. Why? Dr. Uni will tell you the rest of the story. I'm going to stop here. Thank you so much.